we have these 3 drugs, all right? And 2 are on label, 1 is not. Is it important for a practice or for patients to have access to all 3? Or only 1 or only 2? How does that work?
I do believe that it's valuable to have choice for many reasons. And I think the example I put before I use all the time with patients. There's a reason there's more than 1 cholesterol drug and more than 1 blood pressure drug, is that some patients do respond better to one over the other. And I've switched between all 3 of them. I have actually never in my own clinic seen one that bevacizumab works better for, but I've definitely seen some where ranibizumab works better or aflibercept works better. It's nice to have choice.
Is there a way that you could choose a priori and know a priori which one is the best choice?
So far in my practices, I have not been able to tell that.
And people are looking for biomarkers, certainly. With the diabetes space, the worst vision has really helped us to understand where one agent may have a better outcome than another agent. But we're looking for that all the time in our patients.
The other thing to add to that is we know, again, from AMD and from diabetes, that the earlier you start treating people, the better they do and the fewer injections they need.
But if I heard you correctly, it's not just the time that you start, but which drug you use. In other words, if you're going to start early with a less effective drug, that's not, in your view, as good a plan as starting early with a very effective drug.
Absolutely.
Excuse me. What's the role of your professional organization and their policy statements regarding this topic?
Yeah, so the American Society of Retina Specialists is heavily involved with this space, and they're a big believer in choice also. They want all 3 drugs to be available, which I support.
And the American Academy of Ophthalmology also follows suit in that recommendation.
I mean, as you pointed out, the drugs are very different. I always tell them 20-fold difference, right? $50 to $2,000. But so if someone really has no insurance, then it's fantastic that we have access to bevacizumab.
Or for other conditions which aren't covered on label by any of the labeled agents.
I mean, it's also fair to say, right, that it would be great if every drug was available to everybody and every drug was free, right? That would be terrific, but that's not the world we live in. So what factors do you think you need to consider when you determine the cost effectiveness, any new drug, the cost effectiveness and the expense of this drug? How do you start out working that?
Yeah, I think, the first and foremost, it's what drug is most efficacious. And then the question is, what patient needs the most efficacious drug? And we try to balance those the best we can with our medical policies and our pharmacy policies.
So if I told you, let's take the reductio ad absurdum. I've got a drug which is going to cure a disease 100% of the time, but it's going to cost $1 billion. You going to approve it?
No.
Oh, didn't think so. But if I've got a drug that doesn't work and it's free, you going to approve that?
Well,
he's choking.
I don't know of any physician who would want to administer that drug to the patient.
Yeah, let's hope that they would.
But I mean, those are the 2 extremes.
Those are the extremes.
So what I'm trying to get at, in the meetings that you must have, the clinical meetings, to determine how you balance effectiveness versus cost, how do you do that?
Yeah, and we do that by developing formularies that choose the most cost-effective drugs. You mentioned lipid treatment earlier. We don't have all of the lipid, well, we didn't when they were all branded. We don't have all the drugs on the formulary. We choose the ones that were most cost-effective. And then we made others available by exception.
All right, let's take a look at these drugs. And let's take a look at the cost-benefit ratio on the 2 that are on label and then the one that is not. Do you know those numbers? Do we have a handle on these numbers at all?
In terms of cost effectiveness?
Yeah, cost-effective ratio.
Yeah, so I do not have that information at my fingertips, so to speak.
Okay.
And I think that in terms of just looking at either these drugs or kind of the broader segment of probably future drugs, which hopefully does meet a broader population and with more effectiveness. We need to hear from the professional societies. So if a professional society is saying, well, there's really no difference, well, that all 3 should be on label, should be available, that's significant. Versus, you should definitely only have the 2 on label ones as part of your choices. I mean, so professional society is important. We need to have conversation ahead of time before a new drug that's very expensive is released. And we need to know that ahead of time so we can prepare for it.
But here's what I'm hearing. Tell me if I'm wrong. The physician community is saying aflibercept, ranibizumab, these are great drugs. They work. All right. There's one that's off-label. It works, but not nearly as well. So they're telling you that. right? And I'm also hearing that patients don't necessarily have appropriate access to these on-label drugs. Is that what, did I hear that right?
That's true.
So what do you do?
Well, so again, I can just speak from my plan.
Please speak.
So we didn't have the off-label one as an option.
Okay.
We do now. We have left it up to the practicing community to make the choice, and we will cover all three at this point.
Okay, are you going to push back? If he calls you up and says, I'm going to start a patient on aflibercept, are you going to push back and say, please try the cheaper drug?
We haven't, and nor will we in this particular space.
So these two plans aren't pushing back. That's not what I heard you say.
Thank you for not pushing back. I think physician choice and patient access are really important to us.
Okay, but you are getting pushback.
Oh, substantial.
So some other plan. And when you get pushback, what do you hear? What are they telling you?
You know, it is cost. It's driven by the bottom line. And again, unfortunately, we as retina specialists and you as payers don't determine what's being charged for these drugs. Unfortunately, there's no discussion there of value that I'm aware of. And so I tell patients, look, we're going to start in most cases with the inexpensive choice. And if you're not responding, I tell them, look, I'm going to fight for you, and we'll get access to the drug if we need to.
But if I'm devil's advocate, and I heard you say that within days this thing can turn into a forest fire, and I haven't started with the most effective drug, have I done my patient a favor by containing costs?
Well, I certainly think there's a question there. I think, there's bevacizumab is an effective agent. We know that from the trials. We know that from our own experience. And so, I think for me, safety issues, repackaging, those sorts of things are paramount. I don't think that, if I treat somebody with bevacizumab initially, they're going to have a sight-threatening event that I would have prevented by using something the
Okay,
very
so
next
it'll
day.
hold the fort, is what
Yeah,
you're saying.
I think in most cases it will. But we got to understand that there is damage that occurs over time, and policies that implement a plan where it requires us to use a certain number of treatments, to not be able to use our judgment as to when to switch, that becomes more of an issue. If this is that the can is kicked down the road further, then I think we're in a situation where we can end up having some vision losses in cases where we may have been more effective using an on-label agent initially.